welcome back to What Now on the Threshold of Life, Death, and Grief. I'm here in the studio with my friends and colleagues.
Red Keating. David Kennedy.
And I'm Julie Brown. And today we are very fortunate, very grateful that we have another guest in the studio with us, Dr. Kaetlen Wilson. Welcome, Kaetlen.
Thank you for having me. I'm delighted to be here.
Oh, it's so great to have you here. And before we jump into our conversation, I am going to just do the official thing and read a little bit about your bio, and then we'll jump into conversation. So Kaetlen graduated from McMaster University Medical School in 1990. She graduated from the McMaster Family Medicine Residency in 1993 after having done additional training in pediatrics and tropical medicine. She has been a family doctor in the rural Peterborough County since 1993, also working in the areas as a medical consultant for Veterans Affairs, was a hospitalist at our local hospital, was the medical director at the Peterborough Family Health Team, where I was fortunate enough to work with her, and has also been involved with Medical Assistance in Dying, MAID, since 2020, where she was involved in the early discussions in our community at our local hospital, Peterborough Regional Health Centre, regarding the provision of MAID in our community, and then started doing MAID assessments and provisions in 2020. Lately, she's also been involved in working with a group of like-minded colleagues to try to build a sustainable model to provide medical care for the homeless population of Peterborough. And I happen to know that she's a champion for really trying to increase access for primary care, especially for vulnerable populations. And I'm also lucky enough to call her my friend. And we've spent many hours and kilometers walking the trails in our area, talking about issues like we'll dive in today and lots of other things as well. So thank you so much for being here.
Thanks, Julie. Lovely introduction.
So I'm looking forward to this as well because it's such an important piece of our society and our whole idea of life and death and grief and all of those things. Medical assistance in dying has been around legally in Canada for almost 7 years. And so it is a brand new way to die in Canada. And I think that the importance that we can put in there tonight is the importance of understanding and exploring and really getting to know what this is like and what this process is like. And we're so fortunate, and thank you, Kaetlen, for agreeing to do this and to help us navigate in this journey of MAID and to understand the process. We're not looking tonight to talk about whether it's right or wrong or any of those ethical pieces. This is about understanding what is true and what is legal in Canada and very legitimate. And many people have chosen this path. So I think it's very important that we take the time tonight to explore that process and so that we understand that. And we're so glad that we have the expert here to help us with that. So thank you.
Most welcome. I think you're right. It's one of those areas like death that used to be as generally not spoken about. A lot of people have had MAID touch their lives in some way, but I find most people haven't spoken to many people about it. So I think it's great to have the chance to speak about it and hopefully share with your listeners some of all of our experiences with it.
So as we dive in, maybe we can start with, can you tell us what your favorite color is?
I would say red.
Red, okay. Oh, thank you. No, really, we should be, okay, here we go. How did you get involved in your role in MAID? What brought you to this work?
I think it's a mix of, Julie mentioned my sort of passion for equity, and because I was aware of it, being federally passed, but I was also aware of the fact that there was only really myself who's considering it and just a tiny handful of other assessors and providers in our area. So it felt to me that it wasn't equitable to have something that was allowable in our country, but people didn't have access to. So that was sort of the more conceptual part, perhaps. And then I had a family member whose mom wanted to have a MAID assessment, and I was just sort of on the verge of getting involved then, and they couldn't find anyone to assess her. So it was, as a lot of things are in medicine, you just sort of get into it because it's needed. And so it just sort of went from there, really.
An opportunity presented itself.
Yeah, opportunity and need. Yep.
It's interesting. You said something there. How it sort of the opportunity presented itself because there was someone you knew.
Right.
Right. And sometimes knowing somebody, sometimes having that personal connection really helps inform what we think might be the thing to do.
Absolutely. And I think that it's so, it's such a honest, MAID is so profoundly honest, and we can be so profoundly honest with the patients. One of the things that was, I'm 30 years into family medicine, and like a lot of my colleagues, I was getting very tired. And part of what was the most fatiguing for me was sort of trying to maintain an illusion for some patients that there was a whole bunch we could do to change the trajectory of their disease. And they basically knew it wasn't true. I knew it wasn't true. And it wasn't adding anything to their quality of life to just keep trotting out new medications and things. So it allowed me a chance to just meet patients where they were, because when someone's requested MAID, they've thought it through long and hard, and you're past the whole stage of talking about, is there anything else you can do? Well, maybe you should do this, maybe you should do that, and you're all accepting the fact that they are dying, and then it's okay, what can we do to make this as good a death as it can be for you?
Do they share that thought process with you? How they've arrived at that place?
Yeah, it's interesting you ask that, because that's always how I start my discussion with patients, is what started you on your journey to think about MAID. And it's such a telling question. And I think it's often, usually when we do the assessments, family members will be there, not always, but usually. And that question is something that I often get the sense that the family knows the person wants MAID or is being assessed for MAID, but they actually haven't heard the internal process as much of what made them decide, yes, I want to be considered for this. And they'll just tell you so much in that opening statement.
And I think that's the honesty that you were talking about, because people get to a point where, as we talk to all of our palliative clients, that this is the time of your life when you can be most honest. And so I think that's certainly the most helpful thing. Help us, and I think one of the pieces that we all wanted to explore tonight was, and I think you touched on it in your opening piece there about, we don't talk about death, so we don't talk about this piece of dying. And people who haven't connected with a family member or a friend or someone who has done MAID really doesn't have an understanding of the process itself.
Mm-hmm.
And so help us with that. Where do we begin? What's this? And I know there's been changes over these years, and
Yep.
the latest ones have come in, and there's more to come. So it is an evolving kind of thing.
Yeah, it is evolving. It depends on province, but we'll speak for our sakes tonight in terms of Ontario. So the first step is the patient voicing, or we as providers or sometimes family members will have said, is this something that you'd be interested in? When I talk to patients about it in the office, it's the exact same part of the conversation that I talk about palliative care. I see it as part of some of the options that we have. So it's not by any means it's MAID or palliative care. I really see it as a continuation of the dying process if the person wants it. And so really they just need to have said that they want to be assessed. The actual sort of practical step is there's literally a 1866 number that will trigger the assessment piece, and that goes to a regional coordinator who then tries to find an assessor. Locally, a lot of us just refer to each other because it's a pretty small community, as you know. So once the person has done a request, then the sort of formal step is they need to do a written request that is witnessed by somebody. But that piece can happen, and it often does, after they've had the beginning part of their assessment. So the assessment, they need two assessments. Independent clinicians, either physicians or nurse practitioners, can do them. So the two clinicians can information share, but their opinion as to eligibility is independent of each other. And people can also have more than two assessments. So there's a lot of variation in how assessments are done. So if a person was assessed by two people and one person found them eligible and the other didn't find them eligible, then they can request a third assessment. So after the assessments are done, if both of the assessors feel that they meet the criteria, and we can talk about those if you like, then the steps go from there in terms of letting them know about what's involved in the provision and all of those steps. It's usually a process that unfolds over weeks and months. It's not a quick step at any point.
And Kaetlen, would the assessment, so if you are the provider going out to do the assessment, one of those two assessments, would it happen in one time meeting with the patient, or could it be over a series, or how does that appointment look, I guess, assessment look, I'm wondering?
Yeah, I would say the way most of us do it is we'll have a preliminary phone conversation with the patient usually, but sometimes with whoever's supporting them, because a lot of these patients are not doing that well in terms of their stamina and stuff. And that kicks off the process of getting information. So we gather information from their family doctors, their specialists, etc., with the patient's consent for that. And then we go in for basically what is an open-ended conversation. Depending on how that goes, it's usually, I would say we're usually there 2 to 3 hours, which is a wonderful thing to be able to do. I mean, there's so little of that in family medicine. So much has to be done quickly that it's a real privilege to be able to just sit and talk to people. And you learn a lot about them and a lot about their context and who they are. And I find that people's reason for wanting MAID, it's very, very congruent with their values through their lives. That's one of the interesting things that I found, is that people want to exercise the right to die in a manner that fits with how they lived. And then there's lots of questions. There's often tears because the patients, I think, because of the sort of honesty and directness of my questions, I think it allows them to be more honest and direct with their families. There's a certain amount of sort of caring for the family as well that I do, and I'm grateful to be a family doctor in that respect, because you do, although your focus is always on the patient, and it's very much they're the one deciding how they want things to go, what they say and what they're going to decide, you can see that landing on family members, often with quite a thud, and that's hard. So we sort of try and process some of that there. And then I leave them with information. And if they feel they want to kind of keep going for the next step, then I arrange the second assessment. So it's a long, deep conversation, and woven into that is the framework to make sure that the person, or to check if they've met the criteria, and to help determine which track they're on. But it's basically an exploration of their values and who they are and what they want at this chapter of their lives.
We've all kind of found that too, that there's that congruency between, as you get to know them about how they have lived in this world, and so this is how wants to be continued right through there. So I think that's something that
I imagine, yeah.
I'm so aware as you're talking about that, sitting with them for a couple hours, is that you have this clinical assessment that you're there to do and make sure that answer those questions around eligibility. But what I'm really hearing is like this really sounds quite profound, like moment of humanity, of sitting with someone and their family, really processing this very deep way, like their death, but their life, as you say.
Absolutely, because it's an exploration, but it's also, by necessity, there's lots of practical aspects to it. And it's often those parts that really move it to the next level of reality for family members. Patients, I find, are always ready for that, because part of the planning is, do you have a time frame in mind? And I find that patients, in my experience thus far, sometimes they don't, but they don't have any difficulty with that question. Whereas for families, that makes it so real. And it is quite mind-boggling when you think about it, that the person is going to choose a day that they're going to die, and the family is going to know that. That's a lot.
And you're right. Time then takes a whole new perspective in this. We've talked that. I remember that one of the first ones that I was working with, and the day before this person was scheduled, and I spent time with them. They were at the hospital at that time, and they were a lot of anxiety, obviously, and so we took the clock off the wall.
Yeah.
And I said, take your watches off. Forget time and live that. But that's one of the things I think that does introduce into there. Can you help us? So you talk about the eligibility criteria medically. What is that? Who is medically eligible for this?
So if we talk about track 1 first, so the commonality between the two tracks is that there has to be significant suffering. So a lot of the conversation is about their suffering, and suffering is defined by the patient. So there's no external criteria by which I gauge suffering. It's the patient articulating what is the cause of their suffering, and it can be psychic as well as physical, and often is psychic, actually I would say even more than physical. And it doesn't, one of the sort of classic examples that's spoken about among MAID assessors and providers is if the person, for example, was a violinist and they lost the use of their hands, that suffering to them may be intolerable, whereas for myself, that doesn't need my hands for my work as much, I wouldn't deem that. So it's really up to the patient to decide what is intolerable suffering. They have to be competent to understand the decision they're making. So there's some misunderstanding. Some people think that, if the person has any degree of dementia, they can't have MAID. It doesn't work that way. The person has to understand the decision they're making. So understand that it's final, like if they go through with the procedure, it's a final decision. There's no coming back from that. But the person can have some memory impairment as long as they're able to make competent decisions about this aspect of their care. And the condition needs to be serious, and it needs to be not fixable. So irredeemable. So basically, we can't fix it, and it's a serious condition. And then the differences between the tracks is track 1 is natural death, reasonably foreseeable. So again, and that's not very well defined, but it's, you could expect the condition to cause their death at some point in the relatively near future. And the other track is that no, they're not going to die anytime soon from it, but their degree of suffering is such, and there's no cure for it, basically. So there is a lot of subjectivity in the assessments, and that is complex, I think, for everybody, but I don't think there's any way around that.
Do you feel the weight of that personally? That's subjectivity. Do you feel that at times?
I've definitely given it lots of thought, because it's so different than many other aspects of medicine, but it's actually similar to many aspects of medicine as well. It's sort of making the best assessment you can with the information you have. And because it's so profoundly patient-centric, as long as I could remember to keep myself behind the main frame, that allows me to see the patient and what they want. Where it gets tricky is certain things to all of us just feel right and certain things feel wrong. And I've had that before, where I can see that the person would meet the criteria. Like, I could make the argument that they would be eligible. And I've even had cases where I can see that they're eligible, but I don't want to do the provision. And that actually works okay, because the sort of the line that I've used is, you are eligible. I can help you find someone to do the provision, but I'm not that person. So, and that feels okay to me. And I think patients tend to understand that. So it is tricky. Yeah, bottom line is it's tricky. But I like tricky things.
You like tricky and complex.
I do. It's so...
That's why you and I enjoy our walks so much.
Absolutely. It's so real, which is a real privilege.
But that's where life is.
Absolutely.
That's the reality. It's very rarely
Yep.
just clear cut.
Totally.
Did you have a sense of that line as a physician, or does that line present itself through the process?
That's an interesting question. I have a pretty good sense of it, but I'm also aware that there's probably things that inform that line that I'm not even aware of internally. So I'll know it when I see it. I'm not sure how I could articulate it.
I loved that pause.
Yeah.
In the radio, and so it's supposed to have a pause. That pause is important because it's thought.
Right.
There's thought in that pause, and I think that's what I'm getting a sense of. There's a lot of thought behind all of this. It isn't just willy-nilly.
Absolutely not. No, there's a lot of like you hear a lot of references to the safeguards, and there definitely are many and good and appropriate safeguards. But I think the biggest safeguard is that clinicians as a whole, and I've actually never met anyone who doesn't fit within this, they care about what they're doing, they care about patients, and they're ethical, and they'll try and do the right thing whenever they can. So
I can feel that as we're sitting here and as I'm sitting across from you, and it's echoing back to when we had our episode with Dr. Blair Bigham, and he said, doctors, we love our patients. And as I sit here and I hear you talk about, 2 or 3 hours, and it's not just the clinical assessment, it's like knowing them and knowing their values and how does this align. It's like I can hear that coming through.
Yeah, and I think I see some of myself in a lot of these patients, and that I think helps. I mean, they're all obviously individuals, and I'm an individual, but that desire to have some say in each stage of your life. And I think that actually helps protect me as an assessor, because I'm very clear about who I am in the process, which helps it not get any more confusing than it naturally is.
Yeah, I think that's such an important part of our common humanity, and to make our connections on that level. So this is one area, though, these tracks, one area that has shifted since MAID first was approved. And that came about, that language of death had to be in the foreseeable future,
Right.
was something that was shot down and changed. So it is now those two different tracks that you talk about.
Right. So track 2 is where death does not need to be reasonably foreseeable. And the interesting thing is, although it's legislated that track 2 is allowed, track 2 MAID is allowed, there's different safeguards. Like there needs to be a 90-day reflection period, and the assessors need to have specialized knowledge in whatever the condition is that they're assessing the person for, which often as family doctors we do have, like for example fibromyalgia, things like that. At this time I'm only doing track 1 assessments and provisions, and that's largely because we can't even keep up the demand with the track 1 cases. It gets more complicated for me when we're talking about track 2. I don't by any means think that I can decide what anyone else should have to go through in terms of long suffering. But I'm also enough of an optimist, I guess, that I hope, and this applies to the mental health piece as well, I hope that there will be advances that will change the trajectory of some of these conditions. So
It seems to me that's such an important piece to keep in mind. I love the way you present that to Kaetlen, that this is this person's story, this is their life, and yes, it's important for us to give some guidance when we can, but it's not always easy to fully understand that person's journey and story.
no,
But if we're to get to that point, it's obviously significant.
absolutely.
It's not something they just decide on a whim, which I think is a helpful piece for people to know, which is, again, why I'm so glad that you're here to talk about this way. Because sometimes I think people have the idea that it's just, somebody decides and then everybody just makes it happen. But this is a real involved and intense process here.
I would say most patients that I've assessed have been thinking about it usually for several years. Like it's a long time usually.
Like even sometimes pre-diagnosis.
Yeah,
Yeah.
often they've heard about it, or they've had they've known somebody or family member or something, or they read about something about MAID when it first was legalized, and sort of held it in their back pocket, thinking, that would be something I would consider.
And I think that's a very appropriate thing, and we've recognized that too. That sometimes it's just that's all they need.
Yeah.
It's just to have that in their back pocket. And we've all had clients that I've worked with who are very committed to MAID at the beginning, and then as they go on, and this one I'm thinking of, he died, a natural death, but he needed that's in his pocket to say, if it gets to this point, then. but that point was always kind of evolving for him,
Yep.
which is fine. And I
Absolutely.
think it helped him to live better, knowing that he had that decision made.
I'm 100% confident of that. I can actually sometimes feel the temperature going down in the room because the patient, once they get a sense that they're going to meet the eligibility, you can sort of see the vigor coming back, that they feel they have some control of this, and that they are then able to have the, exactly as you said, sort of the mental and emotional space to really embrace the other things that they want to do. It sort of has taken that last chapter off the table. And we reiterate and say over and over again that, like, you can change your mind. Like I've said, like, there would be nothing that would delight me more than if I call you in 2 weeks and you say, nope, call me in 2 more weeks, or call me in 3 months. And that often happens. And that's absolutely fine.
I was just going to say the same thing, that so in many ways it helps them in their own existential distress, in their own processing. And yes, I have seen this where I have had patients who have gone through the assessment where I think we all knew that they probably would not choose it in the end, but it was part of their journey and a really valuable component of that. And like you said, like, just knowing that they had that there gave them some feeling of control. There was comfort in that process for them. And then there are others. I'm thinking of one individual who, the first time I met them, they said, I'm going to be assessing for MAID. And I knew, even as I was getting to know this person, oh, that's the road this is going to go. And it didn't mean that it wasn't, they felt very sure about it. It was still, of course, very hard for them. But we always knew that we were on that road. And as you said, it was very patient-centric.
Mm-hmm. And I had a client use the word, tell me that what would allow him to follow through was resolve. And in his mind, that was his idea. I'm just resolved to do it. He says, I know there's going to be 1,000 different emotions, and I don't trust emotions. So I need to resolve myself that this is what I want to do. This is what I'm going to do. And that was his way of describing that journey at the end.
Yeah, that's very interesting to hear, because some of the population that you're seeing in your work through hospice is some of the same population, but I think some different population. The people I've worked with, for the most part, what struck me has been how it's not that it's not hard, but how simple this is for them as a decision. Like, it just is very, they have thought about it, they've done a lot of this work internally, and sort of it's, I will know when I've had enough, and when I've had enough, I want to go ahead. And the actual day of the procedure, like, not to sound glib, but the happiest person in the room is invariably the patient. Like, they've made a decision, they're going ahead, and they feel confident that it's going to be painless. And they've said what they want to say to people and had their goodbyes. And it's complex, but not complicated in a certain way.
Yeah, I think that's a great point, that you're right, that there would be many of these people we wouldn't ever be in dialogue with because they didn't need us. Yeah.
Yeah, and that is one, especially with track 1 patients, especially when it's older patients, that they can say with pride, I've had a rich, wonderful life. I'm working with a fellow now who's 92, and he doesn't, this is not actually a really sad thing for him. It's sad for his family, but he doesn't see dying as a unexpected thing. He knew he was going to die, and he's pleased that he'll have some agency in how he dies.
So I've got so many places I want to go, but I just want to just do a wee bit of a summary here, because I'm thinking, I'm listening and I'm kind of going, okay, this is going through a process. So I connect with my family doctor, they make a referral, I'm assessed, I am approved,
Yep.
as either track 1 or track 2.
Yes.
Then what happens? Like a day, I pick a date. What happens that day? What does that day look like?
Well, there's a couple pieces. So we now have what's called a waiver of final consent. So if it's a track 1 patient, then they have the option of signing a waiver, which the way the law was before this change was that the patient had to be competent the day of the procedure. And so if they'd had a stroke in the meantime, or a delirium, or had their pain medications increased, and so they weren't fully conscious, as a provider, we couldn't go ahead. And the very first case I was involved with, that actually happened. And it happened on the day that the legislation changed, but before midnight of that day. And I would say that was by far the saddest MAID case that I was ever involved in, because this man was so clear what he wanted, and we couldn't respect what he wanted. So now with the waiver, the patient can say, I want this done on June 1st. And it's an agreement between myself and the patient. So it doesn't work for any other provider. So it kind of requires that you have a high level of understanding of where the patient's at. And that date can be changed, and usually is changed, because the patient may not actually want to go ahead, so you can bump it if you need to. So that's where the date conversation comes in. Right. And
I think that's important, that people know that.
Yep,
when the
absolutely.
day comes, they can change their mind if they so decide.
Absolutely, and that's the norm. Like it often gets bumped, right? And that's totally, absolutely fine. That's totally fine. And then, so if it's a planned procedure, and we're going to go ahead, basically the person has a couple of intravenous's put in.
Can you go back? What happens if they have had a stroke, or what does the waiver do?
So if they've signed a waiver with me, then it means that, like, the wording of the waiver is that I want MAID administered on X date, or at the point that I become incapacitated. So if they had a stroke, then it would be my clinical assessment that they're incapacitated, and they had said they want to go ahead with MAID whenever they became incapacitated. So we would then go ahead with MAID. Yeah, and if they don't become incapacitated, then we go ahead with MAID on whichever day they've chosen. Yeah.
And then what happens that day?
So that day, the nurse comes ahead of time and puts an intravenous in each arm, and then I get there. Usually some of us do provisions on our own. I like to do provisions with one of my colleagues. And we talk to the patient, we talk to the family, we give the patient opportunity to change their mind. I always really emphasize, like, we could just chat today. I could go away again if you're not ready. And people are usually absolutely ready, almost beyond ready, I would say, at that point. And it's important to say that all this time they're having palliative care as well, right? So it's not as though if you're going through the MAID process, you're not also having palliative care. We work with the palliative care docs and the palliative care team, and we get lots of referrals from them. They help with some of the assessments. So there's great collaboration with that. So the patients and the families really feel, I think, very well supported from both sides. And we give, see if the patient has anything else they want to say. And I just wait for the patient to say, let's start. And the death, as we're doing the assessments, I really emphasize that this is your death. You can have it however you want it. If you want it to be outside in your garden, if you want your family lying beside you in the bed, if you want your dog on the bed, whatever you want, music playing, I'm absolutely fine. It's your death. So I really encourage them, and we talked about that at the first assessment, because I think that it can be a really creative process for people to think that through, and probably a hard process too as they work through that with their family. And all of the provisions I've done, patients have had family there, which has been great. One fellow had 20 of his family there. And I think he just, he was the center of the family, and that's the way he lived, and that's the way he went out. And I can tell them with complete confidence that it's peaceful. Because it absolutely is. It's quick, it's peaceful. There's 4 medications that we inject. The patient basically, with the first medication, slips into unconsciousness. And the whole procedure is very quick. It's like about 10 minutes or less.
Yeah, I had a family member say to me they couldn't get over how quick it was.
Yeah.
That it felt very sudden, even though they knew it was coming.
Yes.
That it actually felt quite sudden.
Yeah, it is. I think we spend our whole lives staying alive and working to be alive and living our lives, and then that bridge between life and death is pretty narrow sometimes.
It's a moment.
Yeah, it really
It's
is.
a thin space.
It's a moment.
Yeah.
It's thin space. But I mean, at the same time, I feel that with every death too.
Yeah.
Like there's this, oh my
It's a
gosh,
breath.
they're here and they're not.
Yeah,
Right? There's
that's
that.
right. It's a binary.
Yeah.
Yeah.
So it's not something different in that way. Only that you're deciding on that moment
Yep.
as opposed to allowing that. Yeah.
You mentioned family being present, and that the process is very patient-centered. And I'm an individual, and you're an individual. We're all individuals, but we live in a collective.
Yep.
And family are there. Have you ever run into situations where not everybody is on board the same way that the person is?
Yeah, that's one of the things that, again, where I'm grateful to be a family doctor, because there's a lot of family systems at play, and I actively try and get those out in the open early, because they're very much going to be a factor. One of the pieces I've run into is where family, either the patient hasn't wanted somebody there because they think it'll be too hard for them. That's usually what it is. The patient thinks it'll be too hard for a family member, and I encourage them to have the family member there if they want them there, because I think it is such a peaceful death that what people picture is much worse than what happens. So I think they're much better off to have people there so that the person can see what happens. I've had some real conflict during the first assessment, and it can get really tricky. A lot of anger can come up where people feel like they weren't, this isn't the most patients, but it's tricky when it happens, where they never felt close to a certain person, so it doesn't matter how central they might be in the family system, they don't want them there, and this is when they're going to put their foot down. So yeah, it's all to be processed.
A lot of negotiating.
Yeah, and luckily usually there's as we talked about before, there's lots of points of contact, because I call them in between and after the assessments and touch base and all those things, so and refer them to some reading material, and there's good resources for families of MAID patients as well, so you can see it kind of start working its way through.
I'm wondering about, how has this, what has this taught you doing this work with families, with patients, the process, watching, honoring people's, choice around their death? How has it changed you, or what has it taught you?
I think it's made me more aware of the sort of the beauty of what I can offer as a physician, because I trust that I can do thorough assessments and find the information that I need. And I think we all have the right to a peaceful death. And I'm also very aware of the limits of what medicine can do. And I don't see that as a failure of any of us. I think some of my colleagues can feel like if a patient wants MAID that they've somehow failed them. And I don't see it that way. I think I've had maybe the advantage of working in enough different settings and enough different countries, and that I see death as part of what happens. And I'm just grateful that it is legal in Canada and that it's an option for people if they choose it. I would say it's actually helped me feel more positive about medicine.
There's a lot in the media right now about the issue of mental health.
Yeah.
And that sense of people choosing MAID for maybe non-health related reasons, socioeconomic reasons. How do you hear that when in your ears? How's that informing you, and what do you hear when those discussions are happening?
Yeah, it's so tricky. I mean, I would say my thinking has evolved. So I may have had a different answer a month ago, and I may have a different answer 2 months from now. But I think that there could be a positive part of this, in that the safeguards that are going to be in place, there's a whole bunch of new demographic information that's being gathered with the changes in the legislation. And as an assessor, you have to say that the person was able to access services. You have to basically prove that they want MAID despite having enough access to quality services. And there's often going to be times where the answer to that is no. And I'm hoping that that will help move along some of the equity pieces. I guess I'm hoping that in those cases, those patients won't have MAID, but rather they'll get some help with getting some of the things they need.
Seems the equity is not there in the other side of it, not in the death side of it.
Absolutely.
Yeah. And I think you just hit on something that for me was frustrating from the very beginning, and that was the lack of data. There was a lack of reporting, a lack of statistical information to know who was assessing MAID, and I think that was probably due to a number of things in our society. But it's so important that we do get good data that helps us, not in the decision making alone, but also in the follow up and the care in the grief with families and things that we need to be aware of. So I'm glad there's a change in that.
Yeah, it is tricky for families. I mean, I've seen more of the family grief related to MAID deaths because I'm at the bedside, so I see the acute part, whereas I wouldn't normally be seeing that much of that from a family practice side. I did in the hospital, but I think it is a harder kind of grief in certain ways for the person. I think it can be that the patient's family feel like they somehow allowed this to happen. And at the beginning, I really talked to the patient's family about that. Like, this is the patient's decision, not yours. And I think some of that is to help them realize they're not the one making the decision. But it's not easy for families. But as you said, no death is.
So what is the follow-up that is in this process as well?
So it depends on sort of who the families are connected with. We have good communication with the family doctors. So like they'll know, for example, that Mr. Jones had MAID, and so Mrs. Jones is going to be needing some extra support. There's some good resources for families who've had a loved one proceed with MAID. And hopefully, as it's talked about more, there'll be more informal support as well. I think it is one of those kinds of losses, though, that at this time is more complicated because it's not spoken about very much yet. Yeah.
Yeah, and that's the reason we're also going to have a follow-up episode talking about grief, what we're seeing, what we've experienced, and some of what the literature is also saying with MAID and grief. So as we wrap this to a close, I think we could all ask several more questions of you, but just final thoughts from any of you, or anything that we haven't asked, Kaetlen, that you think you would like our listeners to hear, the family members, people living with life-threatening illness?
I guess the only piece I would add is to encourage patients and families that in the same way they would look into, for example, palliative care options, to also think about MAID. And it may well be that that's not at all something that the person would want, but I think it's something that people should know is available. The main site I refer people to is the Canadian Virtual Hospice, and it has a good section on MAID, and it's situated within all sorts of resources on death and dying, including palliative care and support for families. So I like that setup because it's sort of one of the things that we can offer. So it's not in a separate category. It's really part of what we could offer.
Well, I want to say thank you for helping us tonight, and I do believe that the knowledge and understanding is power and helpful, and I think this is an area that has not been talked about much, and so a lot of misunderstanding gets talked about, a lot of misinformation gets shared, and so having this clear pieces and hearing you, and not just hearing your voice but hearing your heart, I think is a very, very helpful piece for us. So thank you, Kaetlen.
Most welcome.
I just want to echo that, and I love how you said that. It's hearing you speak, but it's the heart from which you speak, and I've found it so moving and touching to sit here and listen. So thank you.
I concur.
Thanks to all of you.
Thank you.
Thanks for listening to What Now on the Threshold of Life, Death, and Grief. What Now is produced in partnership with Hospice Peterborough. Music is by Paradise Garage, and technical support provided by Sean and Jonah Heichert. What Now is recorded at Thin Spaces Studios. You can find more episodes of What Now for free on most major podcast platforms, including Spotify, CastBox, Apple Podcasts, and Overcast. If you want to support us, please follow and leave a review wherever you get your podcasts, and tell your friends. It does make a difference.